Okay, hello and good afternoon, everyone. I hope everybody can hear me well. Yes?
Yes.
Okay, fantastic. I'm Alex Delera. I'm the clinical marketing manager of Mindray. It's an honor to have such a board of experts today and to see so many participants. Mindray is keep investing on education and is totally committed to the education. So I will not take let's say, a big portion of the time because we have a very insightful and interesting topic which will be shared today. So we will have 1.5 hours webinar. I would like this to be quite interactive. As you see, there is a chat box. So during the lecture of the board of experts that we put together, you have the possibility to ask some questions. Which will not be replied in real time, of course, but at the end of their presentation, we will spend some time in order to answer to your questions. So you can just type them in the chat box, and then I will deliver the question to the experts. So we can move to the first topic. Let me please introduce Dr. Chiara Paganotto. Dr. Chiara Paganotto is graduated in medicine and surgery in 2001 at the University of Bologna. After the graduation, she attended postgraduate in the gynecological and obstetrics and was very relevant. She was working in the urogynecological department at the King's College in London, which is definitely one of the great institutions we have in Europe. From February 2018, she's cooperating in the clinic of Ravenna as a medical director of gynecological and ambulatory obstetrics. She's an active member of the ISOG and a leading expert in urogynecology. And definitely ultrasound and instrumental diagnostic of the pelvic floor dysfunctions, which is exactly the topic that she will present to us today. So I will stop sharing my screen so we can hold here the lecture of Dr. Chiara Paganotto, which I kindly thanks to accepting our invitation.
So good evening, everybody. I'm just trying to share my desktop with you all. Fine. Can you see the slide?
Yes, perfectly.
Fine. So I'm really pleased to be here with you despite this world awful situation. And I warmly thank Alex and Ongo, the organizers, for this beautiful idea to connect us all without barriers. My talk, as Alex said before, will be focused on pelvic floor ultrasounds in the evaluation of pelvic floor disorders. So, using the term pelvic floor, we mean the complex system which closes the perineal surface, composed of two main anatomical parts: the muscular support, with its nerves and vessels, and the endopelvic fascia that consists in connective tissue which gives flexibility to the entire system. Both usually described separately. In reality, they are compenetrated, fused one in the other, to form a proper floor for the pelvic organs in order to give a support, but in the meantime, to give the possibility to shift from their usual position and consent the normal flexibility to the entire system, and consent so the physiological function of these organs. This is called a static dynamic balance of contrary forces, and this is an exclusive prerogative of this specific anatomical area. When one or more of these structures are damaged, the balance will be lost, and we could have the appearance of the pathology. In other words, the urogynecological diseases that can be classified in two main groups: the anatomical one, with the famous pelvic organ prolapse, and the functional ones that can occur more often in the anterior compartment with the urinary syndrome, incontinence syndrome, or retention one, or in the posterior compartment, with a fecal incontinence or constipation syndrome. In a big part of patients, we can find also a sense of chronic pelvic pain and sexual problems like dyspareunia. So it's a very huge social problem if we consider that 1 in 3 women will be affected from a pelvic floor disorder in their lifetime. Moreover, what we know about the epidemiology of these diseases is only a small part of the problem, because most of women who are affected from urogynecological disturbs don't speak about them with their general practitioner, considering the urogynecological pathologies as a normal part of the aging process. We know also from the Cochrane database that from 10 to 40 of adult women are affected from urinary incontinence of any type, with an annual incidence from 2 to 11%, and the risk increases with age and parity. But also obesity, limited physical activity, smoking, and associated clinical conditions such as diabetes have a considerable role in the development of pelvic floor disorders. A complete evaluation of urogynecological pathologies should comprehend the past and present clinical history of the patient to understand the causes and the development of pelvic floor diseases, and to eliminate, this is more important, the risk factors and habits which could persist to create problems in the future, especially after the treatment proposed. So it is also necessary a physical examination that should include a vaginal profile evaluation, a stress test, and a Q-tip test for the evaluation of urinary disorders, an evaluation of perineal consciousness and contractility, and in conclusion, a bladder voiding test, especially in patients with pelvic cystosis. We can also integrate our assessment, urogynecological assessment, with different kinds of instrumental diagnostics in order to have more information about the associated functional symptoms referred by patient. We can ask, for example, urodynamic testing in the presence of urinary syndrome, or a proctological evaluation with or without anorectal manometry and dynamic defecography or MRI defecography. But nowadays, the urogynecologists have another useful possibility, the use of ultrasounds. In fact, sorry, I have a problem with, okay. Since 1990s, lots of literature has been proposed through the years to define precise indication and references to how to perform pelvic floor ultrasounds. And in the years, also indications have grown in number and quality, like the introduction of the psychosexual aspect of pelvic floor diseases, especially in the obstetric field. Nowadays, we are in fact trying to know if it is possible to predict pelvic floor traumas antenatally, for example. In this way, ultrasounds acquire a role not only in the diagnosis of pelvic floor problems, but also in the prevention of them. So, ultrasounds could integrate the urogynecological assessment in different ways, evaluating the bladder neck position and mobility, for example. But we can also define a significant prolapse, that means that one possible of surgery. Moreover, we could evaluate and teaching women how to use the pelvic floor muscle, the first line of all urogynecological therapies. We can see the bladder, the urethra profile, and the smooth tissues around them. And so we can also assess the presence of complication after surgery. The 3D and 4D evaluation complete the assessment, giving more information and a better view about the levator and anal sphincter morphology, evidentiating in the meantime the presence of lesions, especially after delivery. Meshes, we can see meshes, injectables, and their complications. All the approaches are valid in the evaluation of pelvic floor ultrasounds. It depends on the confidence we have, that everyone have with a particular technique. So, this is the image that we should see when we place the convex transducer exactly through the labia. This is called the mid-sagittal plane. To take the correct image, we should have in the same scan the symphysis without the shadow cone behind it. You can see it on the left of the image. Because if we see the shadow cone below, we are too much parasagittal, and we cannot assess correctly the pelvic floor traumas. We have then the urethra in all its length. We have to see the urethra in all its length. And in particular, we should be able to, sorry, I don't know if why the presentation is going in this way. But we have to see the bladder neck, which is the part of the urethra just near the bladder trigon, and its mobility in all the scans. Then we have the vagina just under the cervix and the womb. And the last but not the least at our right, the rectum, the anorectal angle, and the puborectal muscle, the more internal part of levator and eye muscle. So let's examine each topic. As certainly you know, we have different causes of stress urinary incontinence: urethral hypermobility, intrinsic sphincter deficiency, and a mix of both of them. In this clip, we have a normal situation. We ask the patient to cough, and we observe the bladder neck. As we can see, its position and the retrovesical angle are quite conserved. As a UGA and ICS report, we can then measure the urethral rotation in different ways. The most used are the bladder neck excursion in respect of the inferior symphysial margin, the alpha angle, and the retrovesical angle. In the first one, considering the Cartesian coordinates in the ordinate axis, if the movement of the bladder neck exceeds 25 millimeters, we can say that the urethra could be hypermobile. In the same way, if the retrovesical angle during stress maneuver increases more than 160 degrees, that urethra could be hypermobile. The alpha angle instead is the angle formed by the anterior margin of the bladder neck following the urethral profile and the symphysis. And if it exceeds 60 degrees with the rotational movement of the urethra, that urethra could be called hypermobile. As we can see from the table, there is a high specificity and sensibility related to this measure in the diagnosis of urethral hypermobile. Considering the large role that subjectivity plays in this type of measurements, in the last year, some big ultrasound companies are trying to focus the repeatability and the feasibility of this type of measures to standardize a technique and make the exam more and more precise and at the same time quick and simple to perform. This is the case of the urethral motion profile, in which the aim is to obtain the real vectors of movement of the urethra, tracing different points along its image on the Valsalva maneuver by using a very complicated mathematical calculation that you can see below. An innovation in this field is also the Mindray Smart Pelvic application, a bidimensional automatical calculation of pelvic floor measures like bladder neck descensus and the urethral angles you saw before, in Valsalva maneuver, simply tracing some fixed point in different times of the image acquisition. We'll see later another useful application of this software in the tridimensional section. Another ultrasound trick that we can identify is the funneling of the bladder neck. When we find an enlargement of the bladder trigon that goes as a funnel in the urethra, as we can see in the image on the right, we can think of two different pathologies: a thinning of the bladder neck due to an intrinsic sphincter deficiency, or to a stretch upwards of the muscularis detrusor fibers due to a massive detrusor overactivity. As we can see, another time we have to be guided by clinic. This is an example of urethral funneling, but in this image is also hidden another type of urogynecological defect, and we will check after if you can find it. So this is another case coming from our clinics. We can observe the presence of both of the pathologies previously described, a urethral hypermobility and a slight funneling of the bladder neck. In this case, probably due to an intrinsic sphincter deficiency, because the only symptom described by the patient was a stress urinary incontinence. Pelvic floor ultrasound, the evaluation of overactive bladder syndrome. The role is not clear. Why? Because for years we have examined the detrusor wall thicknesses thinking that if we have a massive activity of the detrusor muscularis fiber, we would see a thickening at ultrasounds. So we tried to measure the thicknesses in different bladder points or in the bladder dome. And we tried to use a transvaginal or a transperineal approach. In the first one, color evidentiated a significant correlation between symptoms of bladder hyperactivity and an average value of 5 millimeters in the measurement of bladder thicknesses at a bladder filling of 50 milliliters. But when we try to use the transperineal approach, we don't have any average cutoff values at the moment. We know that we overestimate the thicknesses in this way, so the cutoff considered for the transvaginal approach cannot be used. The only cutoff value that we have with this approach is 10 millimeters, but we rarely find in patients who commonly affairs to their daily clinics, because this value is more often seen, in fact, in neurological patients. This English multicentric study published in 2016 confirms the actual state of the art about the detrusor wall thicknesses in the ultrasound measurement, because we know that there is a relationship between bladder wall thicknesses and the detrusor overactivity. The King's College was involved in this type of study. But it's not an accurate method to diagnose for sure this pathology. So we often need the urodynamic testing to confirm the diagnosis. Ultrasounds in the evaluation of pelvic organ prolapse. We have to consider another time the mid-sagittal plane, but in another way. We search the symphysis. We trace a line starting from the inferior margin. And then we observe where the lower margin of pelvic organs are positioned in respect of the line traced. To do this, we have to trace the perpendicular lines and measure them. And we know, thanks to a very interesting work written by Hans-Peter Dietz, that we can call a surgically significant prolapse, that means a stage 2 prolapse, using the pelvic organ prolapse quantification system, when the line traced for cystocele is at least 10 millimeters and 15 millimeters respectively for hysterocele or enterorectocele. In this beautiful image you can see on the right, we see a significant total pelvic organ prolapse. Here we can see a significant cystocele, and we also can differentiate cystocele only from an associated urethral cystocele or cystourethral, because in the first we commonly could have a urinary retention and a low possibility of de novo urinary stress incontinence after surgery. But in the other is probably associated to a urinary incontinence, or a latent one at least. This is a significant hysterocele that is more associated with anterior compartment symptoms if the uterus is retroverse, or posterior compartment symptom is if it is antiverse. Electrocele, rectal enterocele after Bush corpus suspension of Valsalva Marnova. Usually enteroceles that are commonly filled by peristalsing small bowel, epiploic fat or omentum, appears more homogeneous and isoechogenic with the smooth tissues around it, whereas the rectocele is filled by stool bolus, so it results in a hyperechogenicity and with distal shadowing. In terms of rectocele, we can say more than the simple presence. Evaluating the movement of the rectal wall and the anorectal angle, we can guess the anatomical problem that is hidden under the pathology and assess an eventually associated internal defect. If we see only a vertical movement of the rectal wall without any rotational movement of the anorectal angle, we can say that that one could be a pure rectovaginal septum defect. If instead we have a rotational movement of all the rectum and not only of the anterior wall, we probably have an enlarged perineal defect, muscular or facial, and we might have defects of other compartment associated. In conclusion, if we have this arrow-shaped image you can see on the right, In the same time, we can hypothesize the concomitant presence of a rectal or anal mucosa antussusception, which may cause the persistence of an obstructive defecation syndrome after prolapse surgery. So, intussusception is more common in women with an abnormal levator ani morphology, and it's important to try to find it. In this study, we see below Van Grooting compared four imaging techniques, including dynamic defecography and MRI defecography. And the diagnostics result, this is very interesting, were comparable to ultrasounds in the evaluation of lower posterior pelvic diseases. This is a vertical posterior compartment prolapse caused by a rectovaginal septum defect coming from our clinics. It's clear. And did you remember the lady with the urethral funneling we saw at the beginning of this talk? Now you can better understand that she has also a vertical rectocele caused by a rectovaginal septum defect. Ultrasounds can be used also to assess the capacity to find, that means to know where the muscles are and that everyone can control them, and contract adequately the pelvic floor muscles. Patients can also have a visual feedback of their contraction. Also in real-time 3D, we can use three-dimensional tabs to show women how to perform her contractions. And moreover, the physician can teach it, showing on the screen the cranioventral displacements of the bladder neck and the puborectal muscle relative to the inferior posterior symphysial margin. As you can see, this woman is coughing and she's suddenly augmenting her abdominal pressure. She's contracting and relaxing spontaneously the levator ani muscle. This is called the CNAC, which is a normal perineal contraction reflex during sudden increases in intra-abdominal pressures, physiologically present in non-neurological damaged pelvic floor. You can see the relaxation of the muscle on the right. A little mention to this type of masses. The urethral or bladder diverticulum that can be diagnosed sliding the probe up and down on the left, on the right, to find the communication of the diverticular bag with the urethra or the bladder. We can also find that the Gardner duct cyst that differently from urethral or bladder diverticulum doesn't have any sort of communication with the urethra or the bladder. And have a look at this particular case. This woman came to our hospital with a surgical indication for cystocele. At the objective exam, the cystocele was made by a strange consistency. And through the use of transperineal ultrasound, I discovered a prolapse Gardner duct cyst instead of an anterior compartment prolapse that obviously have a completely different type of surgical approach. The bladder, in fact, as you can see, is here correctly positioned just above the cyst. We can also use ultrasounds to evaluate the result of our therapies, like echogenic balloons of macroplastic silicone microparticles used in the endoscopic surgery for intrinsic sphincter deficiency. Or if a suburethral sling is correctly positioned in respect of the urethra and the symphysis pubis to maintain the continence without causing any obstructed urinary flow. Ultrasound can help also in surgery complication. This is a suburethral sling that detached on the right side, as you can see. Or this series of anterior compartment correction failures using meshes. In the first one, on the left, the detachment had occurred anteriorly, and we see the cystocele escaping through the front. In the second, the B image, we see the apical rotation of the mesh, and in the last one, we see a total detachment of both of them. A final particular mention to the ultrasounds evaluation in the obstetric field. where the pelvic floor damage, that is a very common problem after delivery and often passes silently till the menopause. The tridimensional evaluation of pelvic floor in the coronal plane and the obtainment of tomography ultrasounds good quality images are the basis of the detection of the internal or external anal sphincter node repair defects that can cause anal incontinence in years. If we have at least a 30-degree angle gap in the external hyperechoic and or in the internal hypoechoic margin of anal sphincter, in 5 on 9 images of the TUI, the tomographic ultrasound approach, we can strongly suspect an external or internal non-repaired obstetric defect. It's equally important to find also any type of levator ani macrotrauma, better known as levator ani avulsion from the symphysis pubis. If we have a levator urethral gap more than 25 millimeters in the 3 central images of the tomographic ultrasound approach, we can diagnose a levator ani macroscopic defect. We can also find a microtrauma, not a macroscopic one, but microscopic one, when the yatal area of the on the Valsalva maneuver in the coronal image is more than 25 centimeters. About this, the Mindray Smart Pelvic Floor Ultrasound application has another useful application. If we can, as we can see from the video, if we trace 2 fixed points in the coronal plane, the first in the center of the urethra and the other one at the inferior margin of the anal sphincter, we can identify the levator ani margin, and the machine will calculate automatically the yatal area and the levator urethral gap. Of course, if the area measured is not perfect, it's possible to adjust the points, the single points on the profile to obtain a more correct measurement. But why it's important to evaluate the levator ani traumas? It is really important because an enlarged yatal area and a damaged puborectalis muscle insertion on the inferior pubic ramus are very likely to be correlated with an increased presence of anorectal intussusception and the reduction of pelvic floor muscles function by about 1/3. And there are obvious consequences on pelvic floor rehabilitations. But above all, they are also the strongest independent factor associated with the appearance and the recurrence of pelvic organ prolapse. And it is warmly suggested their evaluation as part of the primary urogynecological investigation, especially if surgical treatment is envisaged. Moreover, they serve to estimate the likelihood of recurrence and the potential utility of using anchored mesh, the mesh implants, as a first-line surgery approach. These findings have been also confirmed by our experience, and this manuscript has been published as an original article at the beginning of the 2019. In conclusion, pelvic floor ultrasounds are a useful, quick, and non-invasive tool to integrate and clarify the information obtained by the usual physical examination. Moreover, because of the complexity of urogynecological pathology, it is a huge help in choosing the correct and tailored, more important, therapeutical approach to every single patient. Last but not the least, it has a more and more growing role in the primary prevention of pelvic floor diseases in asymptomatic younger women with concrete obstetric or anamnestic risk factors. Thank you very much for your attention.
Hello?
We can hear you, Alex.
Okay, sorry. I just noticed that I was muted. We can spend just 1 or 2 minutes on a couple of questions. Personally, I would have a lot of questions to ask you. But yeah, I would ask you in private, and I would give the priority to the audience, which is interested to some topic. The first one, it's if you see pelvic floor abnormalities more often in patients with hypermobility form of EDS, and if should the assessment of hypermobility be part of the clinical workup, in your opinion?
Yeah, of course. Because sometimes when we examine physically the patient, we have doubts about the real hypermobility, the urethral hypermobility. So if you put just the probe in the labia, you can have confirms about what you see to the objective in the objective exam. So it is really important to have a ultrasound machine, something near to you to just integrate every type of exam, every single exam, to be more precise, to be more comfortable with the patient, to be more sure of what we will see to her about her therapies, about her approach, about the surgical type of approach. It's very important because sometimes we have very, very low thinking about all these findings we have on urogynecology. And this is a very, very strong support that we can have in all our ambulatory clinics.
Okay, last question. Beside a lot of compliments of the insightful presentation you provide, they're asking if spudental neuralgia is associated with the rectocele anomaly.
Sorry, I didn't catch the question.
The spudental neuralgia.
Okay.
Associated with rectocele commonly, in your opinion?
Not there are no studies about the problem with pudendal neuropathies and rectocele or related syndromes. It's more associated with the hypertone. So when you have pain in the pudendal area, you could have more frequently functional problems like urgency, not only in urinary symptom, the urinary symptom or symptoms of urgency, but also in the defecatory urgency syndrome, because we have problems in the innervation in the neurological pudendal syndrome. So usually there are no hypotonic pelvic floors. We have hypertonic pelvic floors, and the patient are not able to relax the area. So they stay also in stressed position, and they cannot control their functional symptoms or defecation or urgency in the urine.
Okay, thank you very much. We have way more questions, but we will try maybe later on after all the presentation if we still have time. Otherwise, we might invite you also once again for another lecture in the future. If you leave me the screen, I can go
another time.
Topic. So just
of course.
Stop your presentation.
And just
fantastic. And for the meantime, well, thank you really very much for the fantastic presentation you provide. So we move to the second topic today, the preterm birth prevention with the cervical pessaries. Let me quickly introduce our second speaker. We have with us Laia Prat-Corona-Licard, which is currently a physician of high-risk obstetrics and prenatal diagnosis of the German Trias and Puyol Hospital in Badalona, in the northern part of Barcelona. Dr. Laia Prat-Corona-Licard was licensed at the Autonomous University of Barcelona in 2003. Then she had several experiences, and she became obstetric and gynecology specialist at Valdebrona Hospital in Barcelona in 2008. And from 2008 to 2014, she became subspecialized in high risk obstetrics and prenatal diagnosis, which will be, let's say, part of the topic that we will have the chance to discover with her today. And since 2018, she worked as a physician at the German Trias Puyol Hospital in Badalona, as we say, developing tasks for high-risk pregnancy, pregnant diagnosis, fetal well-being, and since 2019, she's also obstetric unit research referee. Thanks really a lot for accepting the invitation. We're really honored to have you with us. So I will remove my screen. Like this, you will have the chance to share yours.
I will share mine.
Perfect. Just click on.
Can you see this?
Perfectly, yeah.
Okay, so, well, good afternoon. It's so good to be here. Thanks, Alex, and thanks, Dr. Paganotto, for such an interesting presentation. As you said, I work in Badalona now, but I've been involved in research on preterm birth prevention, especially using cervical pessaries with the group of Dr. Goya in Vall d'Hebron Hospital in Barcelona. I wanted today to share with you our experience with cervical pessaries and some practical issues as well. As all of you know, preterm birth is one of the main concerns of nowadays obstetrics. It affects, depending on the country, between 10 to 15% of deliveries. 8 every year. Preterm birth is the main cause of neonatal death, being responsible for 35% of it, a total of 1 million neonatal deaths every year. But it also leads to 800,000 deaths as an indirect cause, since it increases the risk of dying for other causes, basically infections. But the problem is not only neonatal death. Preterm birth leads to important long-term sequelae, from audition, visual, or respiratory problems to an increased cardiovascular risk in adulthood, behavioral and neurodevelopmental difficulties, familiar and occupational problems, and economic costs for both families and the health systems. We know pretty good the consequences of preterm birth, but not so good the causes. The pathophysiologic ways to delivery are not completely known in humans, but the pathway is described, and the beginning of the activation and stimulation phases is believed to be multifactorial. There are many factors that can lead to a preterm entrance to the activation or the stimulation phase, such as infection, overdistension in case of polydramnios or multiple pregnancy, cervical pathologies, or bleeding during pregnancy. Is what is called the activation of the common pathway to delivery, a huge syndrome that ends with a preterm delivery but involves many different causes. There are many risk factors described for preterm delivery, like multiple pregnancy, since half of them end in a delivery prior to 37 weeks, a short cervical length, and the admittance for threatened preterm labor episodes during pregnancy, 25% of which end in a preterm delivery, in fact. With all, most of the preterm deliveries do not present risk factors during pregnancy, and many of it are of non-modifiable factors, like ethnicity or a history of preterm delivery. A short cervical length is the main identifiable risk factor for a preterm delivery. Each population has its own cervical length distribution curves. In our population, they were published in 2004, and the cutoff points were established in 25 millimeters at 20 weeks for twin and single pregnancies, and in 15 and 10 millimeters respectively from 30 weeks and beyond. In our research, we chose the measurement of the cervical length as the screening method, since it has many advantages for us. It's useful for the prediction of preterm birth in singleton and multiple pregnancies, in symptomatic and asymptomatic patients that come for routine sonographic screening, in patients with previous preterm delivery, and in nulliparous women, and it has a short learning curve. When we speak of prevention strategies of preterm birth, we usually refer to secondary prevention, because primary is difficult on this syndrome. As we said before, only 20 to 30% of preterm births were identifiable through risk factors, and of these, most of them are not modifiable. That's why we look for secondary efficacious strategies to apply to selected populations, like share clash in incompetence or progesterone or pessary in short cervical length. For those not familiarized with Arabian pessaries, They are a silicone device that is placed around the cervix and then pushed backwards, laying on the posterior vaginal wall, what is believed to let the pregnancy weight lay on the anterior and uterine wall, not on the internal cervical ostium. Here you can see a video that was made by Hospital Vall d'Hebron at the beginning of our research, where you can see how can we place the pessary around the cervix. This is our pregnant lady. The pessary is quite big, but it's really soft, so we have to place some lubrication. Sonographic gel is perfectly fine for this. And as you can see, you have a smaller diameter and a larger diameter. The smaller one has to be upwards. We press the pessary and we place it inside the vagina, so there is not so much discomfort. And once you let it in the vagina, the smaller diameter places around the cervix, and the larger one is pressed backwards, and it lays on the posterior vaginal wall. Monitoring of cervical length is mandatory among the follow-up of these patients, since in front of a cervical shortening, they can benefit from tocolytic treatment, fetal maturation, or even a cervical cerclage. It's difficult because of the shadow the device projects over the cervical canal image. While in the preterm birth clinic, at the beginning of our research as well, we found that if we inserted the probe pressing the posterior vaginal wall, we can introduce the probe inside the pessary and lay the probe on the anterior cervical lip, what allows us to see the cervical canal. Here you have larger images. You can see that when the probe touches the pessary, there is a shadow that hides the whole cervical canal. And when you place the probe inside the pessary, that would be here, this is a colored image we made, you have an optimum view of the whole canal that allows you to do a proper measurement of cervical length. Here you can see a video. Here you can see a video of the procedure. We touch the pessary, we press the posterior vaginal wall, we get inside the pessary, so we can do we have a view of the whole cervical canal, and we can do a proper measurement of the cervical length. The main secondary strategies for prevention of preterm birth are cervical cerclage, whose indications are well established, especially around cervical incompetence; progesterone, that has demonstrated a reduction of preterm birth in patients with prior preterm birth history and in patients with short cervical length, both in singleton and in twin pregnancies, but at higher doses for these last ones; and the cervical pessary, that has shown some benefit in patients with prior preterm birth in small studies and has yielded controversial results in randomized controlled trials on twin pregnancies and singletons with short cervical length. On the other hand, cervical cerclage hasn't shown benefit in twins or in isolated short cervical length. Progesterone is not useful in preventing preterm birth among women with arrested preterm labor and a short cervical length remaining. And we'll see now what's the scientific evidence we have on the use of pessary in these different situations. In 2012, our group in the Vall d'Hebron Hospital published the results of the PECEP trial, in which 385 women with singleton pregnancies had a short cervical length in mid-trimester and were randomized in two groups, pessary and common management. A significant reduction of preterm birth before 34 and 28 weeks was demonstrated, and before 37 weeks as well. A smaller tax of pre-prom was described, and an improvement in neonatal morbidity. As it had described before in that small studies we saw before, all pregnancy carriers had a white inodorous vaginal discharge with no differences in terms of vaginal infection. In 2016, Professor Nicolaides published a similar study carried out in many different countries involving almost 1,000 patients, but without any positive finding in favor of the cervical pessary. In this study, those patients that had a shorter cervical length than 15 millimeters were also treated with vaginal progesterone, what we think could mask the potential benefit of the pessary. Many patients in the pessary group were also treated with antibiotics, but no difference in the vaginal cultures were found between groups. And 10% of the patients requested pessary removal due to vaginal discomfort. Maybe the fact that in many locations where patients were enrolled, there was no previous experience in pessary insertion and management can be an explanation for this data. We'll come back to this later on. Among twins, the first big randomized control trial was the PRO-twin trial that was published in The Lancet in 2013 and carried out in the Netherlands. In it, 800 twin pregnancies were randomized, and at half of it, pessary was placed. No differences between groups were observed in terms of neonatal morbidity or preterm birth rate. But when they analyzed the subgroup with cervical length under the 25th centile, that in the Netherlands is shorter than 38 millimeters, a huge difference was observed in terms of adverse neonatal outcome, neonatal mortality, and preterm birth rate before 28 and 32 weeks. We can conclude then that cervical pessary is not useful for preventing preterm birth among unselected twin pregnancies, but in those with a short cervical length in mid-trimester, it is. In 2016, Professor Nicolaides, the group of Professor Nicolaides published in the American Journal a randomized control trial involving 1,200 asymptomatic twin pregnancies in the second trimester. In this study, also carried out in many different countries, no differences were found between groups. And the same happened when they looked at the 200 patients with a short cervical length at randomization. No data of how many of them were receiving progesterone or how many of them received antibiotics are reported in this study, so we don't know. 1 month later, our group published the PECEP twins trial, a randomized control trial including 137 twin pregnancies with asymptomatic short cervical length in mid-trimester. It was a multi-center study carried out between 2011 and 2014 in 5 hospitals in Spain. Results were promising, with a significant preterm birth before 34 weeks reduction from 39 to 16%. Again, all women treated with pessary reported an increase in vaginal discharge with no raise in the tax of vaginal infection. On the neonatal morbidity field, we can only demonstrate a reduction of low birth weight under 2.5 kilograms, but in this study was not designed to reach these endpoints. Here we see the Kaplan-Meier curve showing a bigger surveillance in terms of continuing pregnant for those women in the pessary group. 2 years later, we were able to publish the result of the PECEP trial that was carried among patients with singleton pregnancies and arrested preterm labor that after the acute episode remained with no contractions but with a short cervical length. In this case, the cervical length was according was according to gestational age, since we included patients from 24 to 34 weeks. So according to our cervical length distribution curves, the cutoff points were established at 25 millimeters until 30 weeks, and in 15 millimeters beyond that point. On this, we can see that the cervical length in the pessary group tended to get longer progressively at 4 and at 8 weeks after the device insertion, while in the control group it tended to get shorter. This happened no matter what the gestational age the inclusion was made. In this study, no differences in preterm birth before 34 weeks, that was our primary outcome, were demonstrated, but a significant decrease in late preterm birth before 37 weeks was observed. Among patients in the pessary group, a lower tax of readmittance for TPL episodes was seen from 20 to 4%, and a lower pre-prom tax as well, from 8 to 2%. The number needed to treat with a pessary for avoiding a late preterm birth is 10. Again, all patients reported a high amount of vaginal discharge, and again, no differences in vaginal infection or chorioamnionitis were detected. Although a trend towards improvement can be seen, no statistical significant differences in neonatal morbidity were found. But as it happened in the PECEP twins trial, this study was not powered to attach these endpoints. Short after our publication, the Dutch group published the results of the Apostel 4 trial. Apparently, it was a similar design, including, but this time, both singletons and twin pregnancies that after an arrested preterm labor had a pessary inserted. Some differences in the design can be pointed out to explain the different results. Patients were included 72 hours after finishing their tocolytic treatment, no matter what was happening at that time. No amniocentesis was performed to add admittance for TPL, what we did, in fact, in our protocol, in order to rule out chorioamnionitis. Maybe this difference can explain why they had to stop the study for futility when 130 patients of the 200 required were included, and they reported a severe adverse effect in one patient for cervical laceration after she presented with uterine contractions. We'll get back to this as well at the end. Last year, our group published a trial after arrested preterm labor, but in twin pregnancies, with 132 pregnant women randomized and even better results, since the decrease of preterm birth before 34 weeks was described, as well as a lower tax of subsequent TPL episodes and bleeding in pregnancy. The pre-prom tax went from 9.2 to 1.5, but without statistic significance. This time, the number needed to treat with a pessary for avoiding a preterm delivery before 34 weeks is just of 7. You can see the surveillance curves showing how the pessary is effective in preventing preterm birth before 34 weeks, but when they reach 37 weeks, both lines come together. Maybe the pessary is unable to counteract the overdistension twin pregnancies have beyond 34 weeks. Again, all patients had vaginal discharge, but no pessary needed to be removed due to patient request. A decrease in low birth weight under 2.5 kilograms, necrotizing enterocolitis, and request of treatment for sepsis was observed, and bigger trials designed to reach neonatal morbidity differences should be performed to confirm these results. To summarize, we can see that the pessary was effective in our randomized control trial in preventing preterm birth among asymptomatic patients with singleton pregnancies and short cervical length in mid-trimester. In 2 randomized control trials carried out in asymptomatic twins with short cervical length, the pessary demonstrated benefit in terms of neonatal morbidity and preterm birth rate before 34 weeks, but this was not seen in Professor Nicolaides' trial. Among patients with remaining short cervical length after arrested preterm labor, the pessary was effective in reducing the preterm birth tax before 37 weeks in singletons and before 34 weeks in twins. If patients are not clearly selected by amniocentesis and clearly remain with no uterine contractions, the pessary can not only be ineffective, but a worsening item as well, as it happened with a patient in the Dutch study. Women carrying pessaries must be clearly advised to consult if uterine contractions appear, and physicians and midwives attending these patients need to know that pessaries are not a maintenance tocolysis treatment, but an external support to the cervix. If contractions are present, it's better to remove the pessary, and then, if we recover control of the contractions, we can insert another one. But the cervical dilation progressing with a pessary in situ can lead to cervical injury. So, we believe that RVM pessaries are a cheap, safe, and reliable tool for prevention of preterm delivery in patients at high risk of preterm birth due to cervical shortening, and even at very high risk due to the addition of other risk factors as twin pregnancy or threatened preterm labor episodes during pregnancy. On the other hand, it's important to clear up some ideas. The first one is that training matters. At the beginning of our research, we believed that everyone could insert a pessary and that it was so easy. But seeing the results of the different trials, maybe this is not that much. In Fetal Medicine Congress held in Crete in 2015, Dr. Franca from Brazil presented interesting data on this. They had been involved in a research with pessaries for the last 4 years, and they realized the results were better at the end than in the beginning of the study, and that's why they compared the results between the patients included the first 18 months with the patients included the last 2.5 years, with significant differences in preterm birth rate and neonatal weight. So they concluded that the learning curve for physicians treating pessary carriers needs to be taken into account, and that it may have big influence in results of big randomized control trials involving non-experienced researchers with few cases each one. The second one is that we are not in war against progesterone. Progesterone is useful in preterm birth prevention, and so, since we want preterm birth to decrease, we love it. The more tools we have, the better. In 2016, in the European Spontaneous Preterm Birth Congress held in Gothenburg, Professor Alfirevic explained that in Liverpool, when they found retrospectively that pessary was better in the prevention of preterm birth among patients with prior cervical surgery, while progesterone had better results when the patient had a history of pre-prom in a previous pregnancy. That is probably something related to some kind of underlying inflammation. Probably, or luckily, in the future, we will be able to improve the targeting of our patients at risk for a preterm delivery, and we will offer the best choice at each patient. Or maybe the many studies going on nowadays will tell us if the addition of different strategies can be useful. Anyhow, both have demonstrated benefits, so any useful tool is more than welcome. And last but not least, always remember that pessaries are not a tocolytic treatment. It will do nothing but harm on a woman who is in active labor or having regular contractions. If this happens and tocolytic treatment is not working, remove the pessary. You'll be able to replace it later if the situation gets better. This is one of the things that when you work with pessaries, you realize professionals misunderstand the most, since they are afraid that if they remove the pessary, the patient will give birth. Well, if she's in labor, she gets no benefit from the pessary. This is one of the things where training is crucial. And the other one, we believe, is to get used to the vaginal discharge and to advise the patients that it will appear and that it means nothing. Over-treating with antibiotics the vaginal discharge can lead to a disbalanced microbiome, which is suspected to be related to preterm birth as well. And well, that's all from me. I hope you liked it. I'll be glad to answer any questions you may have on this topic. And thank you very much for your kind attention.
Well, perfect timing, I must say. Thank you very much. And very insightful presentation. So beside some compliments that you get from the audience, I have two questions I would like to ask you. Then we see if we have time, we can go ahead later on. The first one, if any chance of dislodgements of a pessary when the TVS probe is inserted in the patient.
To move the pessary, you mean with the probe?
No, if you have a chance of any dislodgement of the pessary, if the pessary...
No, not that much. When you retire, if you see the video again, when you
retract the probe,
when you retract, you can push the pessary again backwards, and it's not discomfort for the patient, and nothing happens. We've never had any problem with that. Sometimes,
so you don't have any problem of dislodgement once it's
no, it doesn't come out. It doesn't. No.
Okay, that's good to know.
It never happened to us. Maybe it can happen to someone. But if you do this, usually when pessary is inserted, some kind of edema happens to the cervix. So we think that that's why it gets progressively longer with weeks. Okay, maybe this helps to maintain the membranes. We really don't know how the pessary works. It's not only a physical issue, but it also has something else. But the pessary doesn't go out that easily. Okay, in fact, taking it out is more difficult than placing the pessary. And it's when we have questionnaires answered by the patients, the removal of the pessary usually is worse felt by the patient than the insertion itself.
Rather than insertion.
Yes.
And when the removal happen normally?
In our studies, when we reach 37 weeks, or if the patient got into labor and tocolytic treatment didn't work.
Okay, this we did for the second question. So if we are talking about the gestational age, when do you place it?
It depends on the treatment and the PETSEV one. We were screening cervical length among patients that came for routine scan at around 20 weeks. If we found, if we found asymptomatic patients that had a short cervical length at 20 weeks, then we proposed them to have to get into the trial, and if they accept it, 1 week later we place the pessary. On the other ones, after arrested preterm labor, during hospitalization, previously to hospitalization discharge, if the patient was really without contractions and we saw that short cervical length was remaining, we proposed inclusion to the study and insertion of a cervical pessary before discharge from the hospital. Until 34 weeks, you mean? Because you don't have
24.
No, from 24 to 34.
To 34, okay.
Mm-hmm.
So
the inclusion, and we remove the pessary in external office at 37 weeks if they've reached that.
And what is the best way to remove the pessary?
Yes, that's difficult. That's difficult. Sometimes you get inside the pessary with your fingers and you press the cervix upwards, and you get your fingers pass between the pessary and the posterior lip of the cervix, and you pull, okay? But it's quite harm for the patients. They can do it, but sometimes it's difficult because of the edema. In fact, usually they don't get into labor immediately after the pessary removal. It takes usually 1 week or 10 days.
Oh, okay. Interesting. Last question, because actually it was something I wanted to ask you too. I see somebody from the audience raised a similar question I wanted to ask. There was one slide related to twins. So he was asking if it's, the audience was asking if it's beneficial for twins, also with short cervix in the mid-trimester.
Yes, well, it was in our trial, and in the Dutch trial, that was a huge trial as well. But in Professor Nicolaides, it didn't. Okay, we were trying to look why it didn't work there, and we are convinced that what I was speaking, no, that training matters, training is important. We at the beginning we didn't realize it was, but seeing the different studies, usually among groups that are used to pessaries work fine. In Italy, Dr. Sacon, in Vietnam, Dr. Wang, many places. And when you do randomized control trials that include in India 3 patients, in I don't know where 4 patients, and people that haven't received any training, it doesn't work. It worked for us, and it worked for the Dutch group very well on twins with short cervical length, not in unselected twins, but in twins with short cervical length, Pessary has a paper. Yes, we do believe that.
What's the learning curve? How many patients?
Well, Dr. Franca's study speaks about, for the whole group, around 18 months of getting used to it. Because it's not only the research group, it's the whole hospital. Patients go to the emergency room one night saying that they have some discomfort or whatever, and the whole team has to be used to pessary patients in order to not to remove the pessary if it's not necessary, or to remove it if it's necessary, or whatever. Not only the research group that is on the computer and on the external office and with the consent forms, but the whole team has to be used to it. So it took 18 months for them. We didn't have this data on our team. I think Dr. Goy is working on that, and probably we will have new data on this learning curve. Okay. How many patients for the inclusion, for example, for just to know if the pessary is correctly positioned or not, for an expert physician or for a novel physician, and see if there are differences.
I see a lot of questions again. I will stop the question because, as you said, there might be also some new insights coming in the short future that could be occasion to have you as a speaker once again. So question for next time, or we see if after all the sessions we have time and we can go back to a couple of questions.
Okay, thank you very much.
Very welcome to be back with us. Okay. If you can stop sharing your screen, I can introduce the last, but definitely not the least, speaker of this very interesting webinar. We are talking about ultrasound in the normal fetal heart. Professor Razvan Stanca is assistant professor at the Faculty of Medicine of Constante, Romania. Is an organizer of many lecture and ultrasound academy Constanta course and maternal fetal medicine and med life in Romania. Has been, as you might have seen before, meet him before, let's say, a lecturer in numerous advanced course in ultrasound and obstetric and gynecology. And he's definitely an author of research study in cardiac examination, which will be the topic that we'll introduce to us today. So I will stop sharing my screen so you can take the full control. I just noticed that Dr. Stanca is muted, so if we can unmute Dr. Stanca.
Oh, do you hear me?
Yes, we hear you very well. If you can share your screen, we can see also the presentation.
Do you have also the image from us?
No, we see only yourself now, only with the camera, but we don't see your screen yet.
Okay, so we will start. Now, is everything okay?
Now we start, yes, perfectly.
Okay, so we chose this presentation, especially because the ultrasound of normal fetal heart is very important. Imagine you have to know the normal ultrasound to distinguish, of course, the pathological one. every time we have this quest of the perfect baby. You know that our patients are asking about if the baby is okay, if it's the heart is okay, everything is okay, and we chose specifically this thing, I mean the heart. Okay, but how to see it? Meaning see it is using these ultrasound machines that we have now, and we have to think about the image quality. Why? Because, you know, it's not something that you see very well, meaning the heart has some conditions to be fulfilled so you can see the heart very well. So you have to, first of all, choose your transducer, because it will choose, also it will come with the correct frequency. Then you have to have a high frame rate. Then you have to have high line numbers, because you know it's an organ with very high movements. So you have to have only one or no focus zone. You have to have harmonic imaging, cross beam techniques, speckle reduction, and dynamic range, of course. And of course, you have to have pre and post processing of gray levels. Why I'm putting all this? Because many times when we have lectures, they ask us how can we obtain very nice images, or some of the speakers don't share this experience with this kind of settings. So imagine that what you will see, there are images a little bit older, but you see, if you have all kinds of probes with any type of and all types of frequencies, you will have a very, very broad spectrum of frequencies. You will have very good images. Remember that for the very little hearts, you can also use, and you must use, as this transducer is here, intravaginal approach. So for parameters, you have to know, everybody knows that on the screen is a preset, and the preset is fetal heart, but imagine that presets are always individual, means that for every single patient, you have to have a setting. So you have to understand what's behind these buttons and what's behind the technique of ultrasound. So the presets is a major contribution for your diagnosis. But imagine that we do not need every time a preset, because as I said, presets are always individual. In real life, the problem that we have every time is, do we have resolution or do we need penetration? I put here the frequencies, so we have to choose very wisely the approach and our probe to see exactly what kind of probe we will use for what kind of image. Ideal is to have this kind of patients with this kind of frequencies. So in one word, high resolution, high frequency. In low resolution, you will have low frequency, of course. So for the assessment of the images, I said about transducer, I said about image parameters, but beware to assess a symmetric section through the chest, access the best acoustic window, and this is a big secret. We need a high frame rate for this. We have to zoom very nicely for the correct angle. We have to have a very good cine loop, and every time, or to save it or to use it, and of course to have techniques like sweep and other techniques. But sweep is the main technique when we're using the. So the principle is to assess the cardiac anatomy in different places, biometry, of course, if it needed, and myocardial and valve movements. So imagine that we have this kind of image when we put for the first the probe. Then in this image we don't have, as you see, there is no speckle reduction, no zoom, no compound, of course 14 minutes. So if we do twice the zoom, no compound, but we have this kind of image, and we have a much higher rate of frame rate. Then we put compound, Then we do 4 times zoom, as you see. So now we have a slightly rotation to access different things for this heart. Meaning we do the translation movement. Then, if you want, it's a matter of, every eye is different. For me, it's a very good image when we put sepia tone, and we have all the settings that I said, and we have here a sweep from 4-chamber view up to the 3 vessel view. Okay, so I've just wanted to show you that we start for the fetal heart when we have a little embryo, so where only we confirm cardiac activity. This is a 7 weeks pregnancy. So we with a transvaginal probe, of course, transvaginal probe from lateral view. You have 7 weeks pregnancy, of course, cardiac activity. You cannot say anything else. If you know that it will be in this case, the pregnant lady decided to have an abortion, you can use at least just for showing this stage of the pregnancy, the whole circulatory system. And then the main reason,
Professor,
problem, yes?
Sorry to interrupt you. Sometimes the voice is not very stable and we cannot hear. I don't know if it's due to the microphone. If we can ask to the operator that is there with you to check.
Yes, now you hear a little bit better. We will increase the volume.
Okay, fantastic. Now it's okay. Yes. Thank you.
It's okay now?
Interrupt.
Okay. So we will continue with the 12 weeks assessment of the cardiac activity, which is the first time when we have to do this. So it's a 4-chamber view in this short clip, when we can assess the whole structure of the heart from the 4-chamber view. So it's very important to know that from this point over, even if the heart is 8 millimeters from here to here approximately, we have to assess the elements. So here we have 4-chamber view. Of course, we can use the other approach from the interventricular septum. If we have this kind of image, we can even see that the 3 layers, we call it, of the interventricular septum. Now, with a transvaginal approach, we can even see the left atrium and the entering the pulmonary veins. So, in many studies, they say it's very important to have these 2 different sections with a diastolic flow and the V sign formed by aorta and pulmonary. And these are the main 2 goals for us to obtain from every single pregnancy. Of course, we can do it also transvaginally or transabdominally. As I mentioned, these 4 symmetric chambers in the guidelines are optional. Now we have a clip with that V sign that we discussed at 12 weeks. So you see, it is possible with the correct settings to demonstrate this V sign, which is so important. Again, this time is with high harmonics high and with color Doppler the same diastolic flow. Then we can see even right atrium and the 2 cable veins. It's not mandatory, but it's important to see it because if you have a good view, you can use it, like we have it here. Then, speaking of the tricuspid flux, as we all know, the Fetal Medicine Foundation has some requirements every time, so we will speak also about this tricuspid, meaning we have here, and it was unfortunately tricuspid regurgitation on a trisomy 13, then tricuspid regurgitation for trisomy 21. It's very, if you are very meticulous in having a good Doppler, you will have it very well. And then again, with transvaginal approach, we will observe it's a big regurgitation. It was a monosomy X. So, beginning with 18 weeks approximately, or even 16, but in 18, you see you have a clip here, so you can demonstrate the whole heart, the whole structures of the heart very well, even with transabdominal approach. I was so just for a moment, because we have guidelines, as all know, with every single thing that you have to assess for sonographic screening of the fetal heart, and that's the update from 2013. When we teach somebody else for this basic approach for the cardiac sections, we use also these guidelines with the update from 2010. Why? They are, I think, a little bit nicer, let's say. As you see, we have the major sections here. You have also the longitudinal approach, the longitudinal sections, okay, and then the short section of the heart. So we spoke about these guidelines because they are very important, meaning from the point of view that these they have to be mandatory up to the point of recognizing this, because you can speak about every single major anomaly. The very important thing that you have to begin with is the situs, meaning fetal laterality. So you have to identify the right and the left, different modes of doing this. It's very important to know. Then you have to be very sure that the stomach is on the left. Of course, for the cases of isomerism, this is mandatory, of course, and the heart occupies the thoracic area. And we have the possibility of doing the measurements. The majority of the heart, of course, in the left axis. You can do it just by eyeballing, or you can do the measurements, is up to you. Then, of course, 4 chambers are present, because we have, I said, the section of situs, and that's why you have to have 4 chambers. Then the rhythm has to be regular and no pericardial effusions. As these are mandatory and these are extracted from the guides. Then, for the atrial, 2 atria, of course, approximately equal in size. Foramen ovale flap. It's very important to demonstrate that the flux is from left to right. The atrium, atrial septum primum present, which is near the crux. This is another story, because in every single major pathology, we will have a problem at this primum septum. Then pulmonary veins, like I said, they can be demonstrated from very early moments in the fetal life. And about the ventricles, of course, 2 ventricles approximately equal in size. No ventricular wall hypertrophy. Moderator band is very important, because this band will be the one who will define anatomically which ventricular it is. And then ventricular septum intact from apex to the crux, which is actually not so easy to demonstrate every time. Okay, so about the valves, the crux intact, like I said, this is a little bit tricky. 2 atrioventricular valves open and move freely, because in the approach where we use, you know, we have 2 approaches of looking at the heart, meaning we have the segmental approach, segmental analysis approach, or the pattern recognition. These are not included in this talk, but it's very, very important to have the both valves described and very, very nicely. And of course, the offsetting of the valves, as we know, when we do not have this offsetting, we can think about something related with the interventricular septum. Okay, so now we will illustrate this. If we draw a line, this is the spine, we have stomach, inferior vena, and aorta. But anytime, remember on the images to put where is the head related with this section, meaning below or up in the section. So if we take a picture from the guide, we will have to demonstrate the 4-chamber view, and if we angulate a little bit, we will have the at least 2 pulmonary veins. Of course, you have to demonstrate more than 2, but you can use some other methods. So speaking of the crux of the heart, every time we have to demonstrate that the valves have a little bit offsetting and the crux is intact. Then here you have a little bit of the 2 pulmonary veins. Okay, then from the other approach, meaning the approach will be from an angle somewhere from the scapula, you will have the whole elements of a very good 4-chamber view, which will you will be very sure that every single criteria is there. So I said if we use settings for example here the power Doppler, you will be able to demonstrate the 4 pulmonary veins. Why we have to do this? Because total anomalous pulmonary venous return is a very tricky diagnosis, and many times is not observed in time, and things can go wrong. About the 3-vessel view, we have a 3-vessel view. You can describe the dimensions or anything else, but in one word, you have to have the 3-vessel view present. You have to be very sure that the pulmonary relationship between pulmonary and aorta is the one meaning the dimensions, and then you have the superior vena cava. In the case with the total anomalous pulmonary vein return that was draining in superior vena cava, so it was a supracardiac return, and it was the single sign that we saw, and the diagnosis was made very, very early. So, speaking of, you can have also branching of the trachea on this level of 3-vessel and trachea view. Speaking of the left ventricular outflow tract, this is a picture also from the guidelines. We have to obtain this image when we have, I said, this is the very important portion. Why? Because it's very thin at this level, and you have to have the relationship between the aortic valve, the interventricular septum, and the mitral valve. So this is called the ballerina foot. Professor Gentil named it a long time ago. Imagine if this is the ankle, this is the knee, and this is the tip of the foot. So this is the ballerina foot. Speaking of Doppler, because you know, from the beginning we have to be very clearly about one thing, that every time you have to use Doppler, you will demonstrate different things, meaning here is the ejection jet from the left ventricle, here is the crossing from pulmonary to aorta. Okay, we do not use this as a diagnosis of not having the translation of great arteries, but still you can demonstrate a crossing. Speaking of, again, from the other angle and in Doppler, you see the images can complete themselves. You can have 2 clips in your collection when you finish your evaluation of the fetal heart. Speaking now about the right ventricular outflow tract, we have the first branching, and this is very important because when you will say this is the right ventricular outflow tract, you have to be very sure that this comes out from the right ventricle. Then you can demonstrate between this image and the 3-vessel view. You can demonstrate very nicely if we have the 2 branches of the pulmonary trunk, right and left pulmonary branches. Then, of course, you can demonstrate the bifurcation like I showed you, and of course the pulmonary valve. Speaking of the septum, we can measure the thickness of the septum, but what we care mostly in an image like this, and this is how you have to insonate for having the best image for the septum, is to see exactly the layers, meaning these 2 from the ventricles and the myocardial layer and the movement. Of course, we all know that the septum is squeezing and is not moving towards any ventricle. This is the normal movement. So, I said about the crux of the heart and this interventricular septum, try not to insonate, never ever from this approach, meaning exactly perpendicular, okay. Because if you see here, you cannot say if it's a septal defect or not. But if you do have movement of rotation, and this is the same image from the same patient, you see very clearly that in the same location, only doing a translation of the probe, we have now an intact septum. Speaking of the septum, then we will enter the interatrial septum. So we have to demonstrate that we have the flux, we have from right here to left atrium, and we have the foramen ovale flap. Then, of course, I said about that longitudinal views. This is the aortic arch and the aortic arch branches, which you can demonstrate in power with various maps of color. So if you do the correct settings, you will have the feeling of the three branches very, very clearly. Then, of course, I said that by cable view, if you can demonstrate this, you will be very, very happy about to be demonstrating that you have no interruption of the period in a cable. It can be at some point. Of course, the historic feeling of the two ventricles, as you say, it can be done in 12 weeks, it can be done in 20 weeks, 22 weeks, like it's here. Of course, the data arch in two different approaches with two different types of Doppler. I always say this: different types of Doppler, different types of profs, different types of settings, because people have different machines, have different settings, and they have to know and to understand how to obtain these images. And then I said that we can demonstrate this crossing, but first of all, we have to do these three techniques to be sure that what comes from each ventricle is bifurcating, is not bifurcating, the V is present. So this is the main technique of obtaining that very, very nice diagnosis of not having any transposition of great arteries, because as you know, the transposition of great arteries is many times missed in prenatal life. Then the same image can be demonstrated in color, and the normal Doppler has to be very, 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 very well set up, because also the flux and the direction of the flux has to be very, very well presented. Of course, we have here the main arterial trans that you have to document, and you can also have it in these clips. Okay, the short axis we have here, what we call it the mitral valve section. This is the short axis of the heart, and we call it here the fish mouth section, which is this, the mitral valve. And of course, it's not mandatory, but many times, if you can, this is a clip with a high resolution probe. You have to have the leaflets of the aortic valve. It's important because when we have when we don't have 3 leaflets and we have 2 leaflets, we can have a possible aortic coarctation. So, as I mentioned, the mitral valve spectrum can be assessed, and it's very important to have it here. Then, the tricuspid valve spectrum. Then, of course, pulmonary artery valve spectrum, and not only the spectrum, I mean also the velocities, which have to be documented every time. The aortic valve spectrum, which is important, is very important in any kind of pathology. And then, of course, ductus arteriosus and ductus venosus in cases where it needed. We only put it here to show that they can be very, very nice documented. So remember that the heart is evolving. So you have here from 28 weeks to 32 weeks and 36 weeks. Okay, it's a very nice image, this one, but it's very hard to obtain. But we have to be very, very carefully and to look upon the heart for the entire duration of the pregnancy. So, in conclusions and take-home messages, use the sweep and rotation techniques because you cannot see, you cannot obtain good images without it. Adjust your machine on every single patient. As I mentioned in the beginning, we cannot have presets for everything. You have to use the sequential segmental approach, meaning you have to be sure that every single time the left and the right heart are correctly connected and the main arteries are correctly emerging from each segment of the heart. The position of the heart and the rhythm of the heart, of course, the insertion of AV valves, the ventricular proportions and structures, because as you know, for example, the hypoplastic left heart syndrome is very easily to be recognized. We don't have to be experts on that, so it's only a matter of looking very nice, very well for that. And of course, like I said, of the great vessels, always, but always, you have to check this view and three vessels view, three vessels and trachea view, which are the main two sections that you have to have in your reports. And if you have questions, or if you want to teach, or you want to send and reach for help for a diagnosis, use also the 3D techniques to complete this diagnosis for a second opinion, or for archiving for yourself. So this was a very, very short presentation for the normal structures of the heart, and I thank you very much for your attention.
Thanks to Dr. Stanka. Unfortunately, the audio was incredibly weak, so we couldn't, let's say, perceive all the quality and the quantity of information that we got. So I kindly asked Dr. Stanka in the next future if we can record the audio of his presentation again. So we are planning, after the approval of the expert, to upload these presentations, I mean these videos, okay, to provide a replay features. So for the current speaker, we will just use the one that we did, but for Dr. Stanka, probably we might need to record it again. I hope it's not going to be a problem for that. In terms of safety, we had a kind of question. We wanted to know, let's say, if before than 10 weeks, is it considered safe to perform a fetal Doppler to fetus?
Yes, before 10 weeks, as I said, we don't use it. We use it using the ALARA principles. So ALARA principles means that every time you have to use the less Doppler that you can, the less energy that you can. All these cases that we present with Doppler are only the case from the women which are interrupting the pregnancies. Of course, we do not use it frequently.
And then are asking the add-over of 5-chamber view over 4-chamber view.
Yes, the 5-chamber view wasn't presented here because 5-chamber view, I mean, it wasn't presented like, you know, as a basic examination. It's a very important section, okay. But we mostly use 4-chamber view, and then we switch to, or we try to switch to 5-chamber view, but mostly we use the view with that I showed, the view with the septum. Every time we have to be very sure for the interventricular septum in subaortic view, exactly for the perimembranous portion, to be very sure. So in my opinion, it's mostly usable the 4-chamber view, and then in transition to that, of course, it's 5-chamber view with the aorta rising. but mostly we have to concentrate on the perimembranous portion of the septum.
We have a specific question on image quality, which was a part of one of the main part, let's say one of the main pillar of your presentation. Asking which value of PRF you would recommend for a fetal cardiac study.
I've told you we have special lectures for this. Every time everybody asks about this PRF.
It's a hot topic.
Whatever. Yeah. So the velocity was between 3 to 5.5, but it depends on the machine. This filter is the most important thing in Doppler in the heart, because velocity has to be from between these two values, okay? But again, it's a matter of every single patient in every single situation.
Would you recommend to start with an higher PRF and eventually decrease it in case?
No,
or on the other way around.
Exactly opposite. We do very low PRF, then we say, okay, I don't see anything, so something is wrong. And then we increase. We increase the velocity up to the point, because this is another story. We increase the velocity, so we have the higher PRF, but then you will not have the correct feeling of the ventricles, the great arteries. So it's not only the PRF, but at least it's a start. So you start with lower PRF, and you increase PRF up to a point when it's convenient for you. Then you have to adjust something else. Meaning the filter for the wall motion filter, which again, it's a very important setting. I've told you, it's a whole new lecture only with settings for Doppler.
And then we will make a next time a dedicated lecture on that. I think we can take more than half an hour on the PRF thing. Well, I'd like to thank you all, to thank Dr. Pacanotto, Dr. Prat-Corona, and Dr. Stanca. It has been very appreciated for the message we got. Technical problems and time are there. We can't avoid it, but we can definitely find a solution. So we will be able to share with you the presentation in the near futures. I'd like to thank you all, really, the participants also that stay connected with us. We had almost 300 people connected today, so it was really a pleasure to having you all. We will let you know about the possibility to replay the video for the one I've missed it, or if you want to share it with your colleague. And I'm looking forward to see all the three lecturers that we had today in the next session. Since there are a lot of questions unanswered, we can keep it for the next session ongoing. Well, thank you very much to all of you, and then compliments for the very insightful presentation you shared with us.
Thank you.
Thank you very much.
Thank you very much.
It's been a pleasure.
Thanks a lot. Bye.
Bye-bye.
Bye.